This is the Healthcare Marketplace Specialization, Healthcare Marketplace Overview. I'm Steve Parenti, and this is Module 1.2.2, Market Evolution, Post-World War II. After World War II, so much of this healthcare market changes, and it's probably where the United States really takes its major trajectory away from most of the industrialized world. One thing to keep in mind is that in post-World War II, by in effect winning World War II and the rest of Europe and particularly Asia is kind of bombed out from World War II, it gives the U.S. throughout the 1950s a tremendous economic advantage. So our national income is increasing dramatically, much more so than most other folks. For example, in the UK, they still had gas rationing until really 1960. There are massive increases in federal support for medical research that are going through the National Institutes of Health. What that translates to for consumers and physicians is the growth of what's called fee-for-service medicine. You need to get coverage. You need to get services. You'll have probably a Blue Cross Blue Shield plan. They grow throughout the entire country at this point on a regional basis, and you get that care. A fee is presented. You give it to Blue Cross. They pay whatever the physician's really asking. There's lots of patient-driven competition by the hospitals and physicians. Meaning that they're trying to lure in as many different patients as they can. And then the other thing that happens too is, recall we talked about that wage freeze in 1943 that was just a temporary measure to get folks through really a 6-month recessionary cycle. Well, turns out the government comes back in 1954 and says, you know what, employers and unions, we're giving a lot of money away here tax-free to employees, not to the firms, mind you, to the employees for getting essentially this benefit without having taxes on it. It's a wage substitute. That's why it was put in place in 1943. And turns out the unions and the employers lobby hard enough to get to Congress to say, you know, we want it this way instead. And actually they get enough votes to go the exact opposite direction and get the Revenue Act of 1954 passed, which basically enshrines that health insurance will be essentially a tax-free benefit that's paid by employers to employees. Again, today that is about $260 billion a year, non-trivial chunk of change. 1960 to 1970, beginnings of genetic research really gets underway. In the 70s, actually gets a really amazing path-breaking company, say in not Silicon Valley, but closely related to it, Genentech in the Bay Area. We see health manpower that is not having enough physicians and primary care physicians lead to additional educational subsidies to get more folks to enter primary care. Actually, we get to see people being recruited from overseas countries to come and provide medical education. Medicare and Medicaid, we'll talk more about them later in the insurance, but become major programs for Medicare for the elderly and aged and disabled, and then Medicaid for the poor. Across the U.S. to basically give them health coverage. And this is really a compromise to having national health insurance under the Johnson administration. People think of it as that was the goal. It wasn't the goal. What was impressive with this, though, is that physicians and hospitals supported it. And the reason why they did was that they more or less took the private Blue Cross Blue Shield plans and just essentially outsourced that same function for Medicare and Medicaid recipients. There was a shift from rest homes to nursing homes for long-term care. And then the Harris-Capel Drug Act, basically promoting competition in the pharmaceutical industry and strengthening some of the other protections on drug safety. We get to the 1970s. We start finding ourselves in what's called a medical arms race. It actually started mostly in the 60s. Here we find hospitals basically competing for patients and saying, we have brand new scanners, we can get you at any time, we have different surgeries we can do, and this all drives healthcare costs higher. One thing that is proposed to keep healthcare costs lower is the Health Maintenance Organization Act of 1973. This term, Health Maintenance Organization, actually termed by a physician in Minnesota who proposes that everybody needs to go through a gatekeeper that's a physician, that's a door there, and that they would essentially have to go through. Hard to believe that's a door, but you're going to have to trust me on this. And the thought being that once they get through that door, then they can go to a hospital or they can actually see a more advanced primary care or a specialist setting. Also in this area, we see hospital inflation growing very rapidly. and it's because it's cost-based. You basically submit your bills to get paid. We see the passage of this notion of certificate of need, meaning that state governments have to now approve through a sort of health planning agencies whether or not you're going to get your new technology if you're a hospital or not. That's a pretty major oversight by government. We also have ERISA. People may think of ERISA because of 401ks that they might have as employers. What it means, though, for healthcare is that employers now get to essentially run plans that are exempt from state regulation. So if, for example, a state government says everyone must have abortion benefits, essentially the employer can come along and say, nope, that's not going to be the case. Now, granted, some things changed with the Affordable Care Act passing in 2010, but this gave employers tremendous freedom to develop new types of health plans. The Nixon administration proposes national health insurance actually with Ted Kennedy, a Democrat, and Nixon being a Republican, but the legislation does not get passed. In the 1980s, 1990s, we have really a major public health crisis in the form of HIV and AIDS. Nothing really seen as dramatic and sweeping as a crisis like that since tuberculosis in the early part of the 20th century, late part of the 19th century. Dealt with quite differently. There weren't sanatoriums built for folks with AIDS, but there was definitely a drive to find a cure, or at least solutions for technologies to treat it quicker than possible. There is a development of what's called the prospective payment system for Medicare. What that means is that as opposed to paying by charges, which is whatever you want, we'll pay you by day, that system is done away with, and instead is replaced with essentially a cap of dollars per day, or per admission, and which actually requires a lot more information technology systems to actually verify what those pieces will be. There is, because of shutting down the inpatient world, mentioning you stay overnight, a shift from inpatient care to outpatient care because that world is still charge-based. This is where you see some interesting games going on in finance here in healthcare. And then the Waxman-Hatch Act promotes more competition in generic drugs in the pharmaceutical industry, which really makes generic drugs in particular, much more accessible to the market. So a lot of things happen when we think of the 1990s through the present. Public health issues, increasing rates of obesity, with 30% of the population technically in a range of obesity by 2002. Diabetes prevalence going along with that. Obesity piece of it. We see another form of national health insurance, not quite as comprehensive, the Clinton's Health Security Act in 93, 94, that fails. Managed care, that is the HMO pieces, actually take off pretty dramatically. They expand into the Medicare market. They also expand into the Medicaid market for the poor. And actually, by now, when you get to 2014, I wrote an article on this, you're now looking at about 70% of Medicaid is actually now managed by Medicaid corporate agencies, insurers. Provider consolidation. We see a lot of mergers and acquisitions by hospitals and physician groups. The solo physician is essentially going away. People talk about this in the 90s, the idea of the managed care nightmare, meaning that they can't get to see the doctor they want, that there's lots of bureaucratic restrictions. That leads later to reducing those restrictions, and then healthcare costs increase a bit, as we talked about in the 2000s earlier in the module. Balanced Budget Act of 1997 cuts Medicare payment rates for physicians, though some of them don't go immediately into effect. It creates a lot of crisis for hospitals. For physicians, it's later kicked down the can for quite some time until it's finally resolved, actually until 2015. Nursing shortages become a major issue as well, particularly in California, as that market expands Medicaid for their population. For pharmaceuticals, we actually have Medicaid drug rebates imposed basically to lower the price of prescription drugs for folks of the poor. On the private side, we have these things called PBMs, pharmaceutical benefit managers, that actually start to take the pharmaceutical market away from private insurers and essentially contract it out because drugs become so much more complex as brand new products, Prozac and other things come on market that really are quite more dramatic. We also will have for pharmaceuticals, first time ever, direct-to-consumer advertising permitted. It may be hard for some folks that are younger to believe it, but there were no drug ads on TV prior to 1997, as opposed to them dominating any morning TV show today. And then Medicare Part D, this is a prescription drug act for seniors, comes online in 2006. Going forward to 2015, there's lots of things that happen on the insurance frontier. We have what's known as HIPAA. People think of it as privacy. It's not. Actually, it's about reforming the health insurance market. Privacy was specified as something that had to be dealt with by 2000 if it was not dealt with in the Senate. There was a managed care backlash, as I mentioned, in '98. There was an expansion of the Medicaid program called SCHIP, or CHIP, Children's Health Insurance Program. There were medical savings accounts first developed in 1996, which later evolved into health savings accounts by 2003 in legislation. Health insurance costs dramatically increase. They go from $4,000 per individual in 2004 to basically by 2011, $15,000. The uninsured ride quite a bit. Now, granted, they go down much more once the Affordable Care Act passes and becomes fully implemented, or mostly implemented, I should say, by 2014. And then by 2015, we actually see the number of uninsured down to about 40 million or so, a little less. So here's a thought question. In what way does the global healthcare marketplace influence U.S. healthcare markets? No right or wrong answer. Just think through what your responses will be and please share. This concludes this module on the post-World War market evolution in the healthcare marketplace.